Good morning. Convening our Committee on Health and Homelessness. Today is Wednesday, March 13th, 2024, 9 o'clock a.m., conference room 329. This is our hearing with a number of bills in advance of our triple referral filing deadline. To those of you in the audience and to those of you on Zoom, welcome. Just a little bit of basic ground rules. I do not typically impose time restrictions to testifiers, but I do want to urge you that we have a heavy agenda, so please use your time wisely. We do have your written testimony if you submitted it, and we do want to provide time for questions of any of the legislators. For those of you participating on Zoom, if we should lose you by contact for some technical reason, we will recess the meeting and then properly reconvene it as appropriate. I think that's all the, yes, I think that's all the ground rules that I need to take care of. I want to thank our staff for all our hard work. So let's jump right in. First up, we have Senate Bill 2556, Senate Draft 2, relating to Community Outreach Court. We have testimony in support from Department of Human Services. Testimony in support from the Judiciary.
Good morning, Chair Belatti, Vice Chair Takinouchi, and committee members. I'm Brooke Mamizuka, Social Services Manager and Probation Administrator. The Judiciary strongly supports Senate Bill 2556 SD2. The Community Outreach Program has changed many lives. It has helped struggling individuals and their families get back on their feet, gain self-esteem, improve their living conditions, family life, and community. The Community Outreach Court does more than resolve legal issues for our clients. It provides us an avenue to help our community. The Community Outreach Court team is made up of judicial clerks, bailiffs, social workers, attorneys, and judges, all of whom step outside of their roles and give us and others in need. The Community Outreach Court team connects the Judiciary, Office of the Prosecuting Attorney, and Office of the Public Defender, and 24 partner agencies. This is a small way that we are making a difference in our community. The team brings safe and accessible links to courts, SNAP benefits, replacement IDs, employment, clothing, transportation, car seats, food, housing, school supplies, bed linens, bus passes, and wound care, most of which are donated by judiciary employees and agencies that open their minds and their hearts to helping the outreach program and our community. The program has been in existence since 2017. Outreach in court hearings in the community takes bailiff, social workers, judicial clerks, equipment, security, and transportation. Staff and auxiliary assistants are borrowed from other programs and courtrooms. Over the last 7 years, our population and services have expanded to meet the needs of the community. Unfortunately, our staffing and equipment have remained unchanged. What we have are devoted public services that are committed to helping our community. Our social workers bring fans to cool humid conditions. Our judges help to purchase our awards for our graduates. Our court administrators create bed linens, clothing, and school supply drives to give to our families in need. Our driver education technicians work with the Honolulu Police Department and Kipsi to obtain child passenger seats for our keiki. We are asking the legislature to help us take care of our community. The judiciary respectfully requests that the effective date of July 1st, 2015 on page 9, section 11 of this bill be amended to take in effect July 1st, 2024. We humbly request that the House Committee on Health and Homelessness approve Senate Bill 2556 SD2.
Thank you.
Thank you.
We have in person Michael Vincent from the Department of Law Enforcement.
Good morning, Chair Belatti, Vice Chair Takinouchi, members of the committee. My name is Michael Vincent. I'm with the Deputy Director of the Department of Law Enforcement. The Department of Law Enforcement strongly supports this measure. This bill is part of a host of behavioral health measures moving through the legislature right now, and it addresses an important element with a certain segment of our community. Criminal justice reform has been around for a long time, and there are elements of criminal justice reform that have historically and consistently proven to be very ineffective because they only benefit the criminal. There are criminal justice reform measures that have historically and consistently proven to be beneficial, and this is one of them. These are programs that are designed not to just benefit the offender, but to help the community as a whole, to help the offender. And not every offender is a criminal. Granted, all criminals are offenders, but not every offender is a criminal. And there are people that being locked up is not what is needed to help them, to help the community, to help their families. And this is one of those bills to help that segment of the community to have some options so that we can actually get them the help they need so that they can actually be good members of our community. The appropriation that we're requesting is for make sure that we always have some deputy sheriffs who can always participate in and go with the criminal outreach court team as they travel out to have their proceedings and do their work. And that's what the appropriation is for. Thank you very much. I'm here to answer any questions if you have any.
Thank you. Mr. Vincent, is it lieutenant? Is it
No, I'm a deputy director.
deputy director? Okay, deputy director. We have testimony and support from Statewide Office on Homelessness and Housing Solutions, Mr. Mizuno. We have testimony in opposition from the Honolulu Department of Prosecuting Attorney in person.
Good morning, Chair Albalati, Vice Chair Takenouchi, and committee members. I'm Paul Mao. I'm the Chief of Staff for the Department of the Prosecuting Attorney. I'm standing in for Brooks Bear. I'm here this morning in opposition to SB 2556 ST2. We're primarily here to ask for amendments that are not included in ST2. While the Department of the Prosecuting Attorney continues to support the Community Outreach Court, we're going to ask this committee to focus on, one, the public defender's request to end their role as the pass-through agency for the Community Outreach Court. Two, support for the expansion in other communities by increasing the funding of additional personnel for the Office of the Public Defender, the Judiciary, and the Department of the Prosecuting Attorney. SB 2556, as it's now proposed, creates a new chapter in the HRS for the Community Outreach Court, which we feel is unnecessary since the judiciary is already permitted to create and/or participate in any specialty courts or projects that it chooses. The existing Act 55, which was passed back in 2017, established the Community Outreach Court and set processes for the program. These are critical processes that are spelled out in Section 4 of Act 55, and these processes weren't included in SB 2556 as it now stands in SD2. They are necessary to protect the community. The program under Act 55 allows the disposition of cases when the prosecuting attorney and the public defender have negotiated and reached a plea agreement on the disposition of defendants. Agreement between the prosecuting attorney and the public defender is essential to prevent admission of inappropriate defendants into this program, into the Community Outreach Court. And just to be clear, Section 4 spells out that defendants must be nonviolent, charged with a non-felony, appropriate for participation. That's what the two sides are agreeing to. I'd like to thank you for this opportunity to testify, and I'm available for questions.
Thank you. We have testimony and support from Hawaii Substance Abuse Coalition, Alan Johnson, and testimony and support from ISIS Usborne. Any other testifiers in the room? Any other testifiers via Zoom? Any late testimony? Seeing none. Members, questions? Seeing none. Moving on to Senate Bill 3129. Members, this is our bill with the Hui Ho'omana Task Force. We have testimony and support by the Department of Human Services. Testimony in person, comments from Commissioner Ito.
Good morning, Chair, Vice Chair, members of the committee. Gordon Ito testifying on behalf of DCC Insurance Division. We sent our written comments supporting the intent of the bill. Thank you.
Thank you. Testimony and support from Hawaii State Council on Developmental Disabilities. Thank you. Testimony and support from Hawaii State Health Planning and Development Agency. Dr. Lewin, in support.
Aloha, Chair Belatti, Vice Chair Takenouchi, and members Kobayashi, Martin, Amato, and Garcia. Good morning. Yes, we propose this and support this this task force. While a short-term task force can't solve all the problems and the challenges we have in healthcare, it can describe the experience, the thinking, the priorities, and the vision of those who are charged with providing the care and those who receive it. It also will include the appropriate government agencies. We haven't had this kind of a big vision for well over a decade. We think it will be very helpful. The governor feels it will be helpful to our future vision about where healthcare should go in an ideal circumstance. We support the current draft of the bill.
Thank you, Dr. Lewin. Testimony in support, Executive Office on Aging. Testimony in support, UH School of Medicine and School of Nursing. In person, comments from Kaiser Permanente. And comments Hawaii Pacific Health. In person, in support, HMSA. Okay, thank you. In support, Aloha Care. Comments, Healthcare Association of Hawaii. Thank you. Testimony in support, Hawaii American Nurses Association. Testimony in support, Hawaii Primary Care Association. In support, ARP Hawaii. In support, Hawaii Association of Health Plans.
Good morning, Chair, Vice Chair, members of the committee. Rachel Wilkinson on behalf of the Hawaii Association of Health Plans in support. You have our testimony before you. I just wanted to point out that we are respectfully requesting that a representative from the Hawaii Association of Health Plans be added to the work group. Thank you for the opportunity to testify.
Thank you. We have testimony in support from Hawaii Medical Association. Comments from Papaʻololakahi. Any other testifiers in the room? Any other testifiers via Zoom? Any late testimony? Seeing none, members' questions. Go ahead.
Dr. Lewin, is the task force able to do its work within 1 year?
Our preference would be that the task force issue a final report before the following legislature, because we think that there'll be, since it's a really no-cost item, if there are reflections that come from next year's legislature, we think that we ought to take those into consideration and return 20 days before the subsequent legislature with a final report. So for that reason, we would amend a little bit of the extension of it.
Thank you.
Thank you. Any other questions? Seeing none, members, moving on to Senate Bill 2682. This is relating to lead poisoning and mandatory testing. We have testimony in support from Department of Health. Thank you. Testimony in support from Hawaii Chapter of American Academy of Pediatrics. Testimony in support from Healthy Mothers, Healthy Babies Coalition of Hawaii. Testimony in support from Michael Ikiem Older. We have late testimony in support from Hawaii Children Actions Network. Any other testifiers in the room? Any other testifiers via Zoom? Members, any questions? Okay, seeing none, moving on. Senate Bill 3125. This is another governor's bill. This is regarding minor consent for prevention and for STIs treatment. We have testimony in support from Department of Health.
Department of Health stands on our written testimony.
Thank you. Testimony in support from Planned Parenthood.
Yes, hello, Chair and members of the committee. My name is Rachel Kinsey, and I'm here as the Policy Manager for Planned Parenthood Alliance Advocates. We stand on our written testimony and stand in strong support of SB 3125. Thank you.
Thank you. Testimony in support from Hawaii Health and Harm Reduction Center, Heather Lusk. Support Drug Policy Forum of Hawaii. Support Opportunity Youth Action Hawaii. In support Essential Access Health. In support Parents and Children Together. In support Hawaii Academy of Family Physicians Legislative Committee. In support Stonewall Caucus of the Democratic Party of Hawaii.
Madam Chair?
Yes. Go
Hi,
ahead.
good morning. Michael Galoyu Jr. on behalf of the Stonewall Caucus for the Democratic Party of Hawaii. We stand in strong support of this bill. We just want to point out that in this state, a minor can seek help for if they contract a STD, but they can't seek prevention. And this will help that will help flip the script on this and help save lives and protect our keiki. So we encourage you to pass this bill and to make Hawaii a better, safer place for all those who call home. Mahalo.
Thank you, Mr. Goloyu. We also have you in support for Rainbow Family 808. And I assume that's the same testimony. Moving to Keikoa Kealoha, individual in support.
Hi, good morning, everybody. Thank you very much for this opportunity. I apologize, my testimony was a little bit late. I hope you're able to review it because it's going to make a little bit stronger of a case for me. I think that everybody here wants the same thing. I think we all want a healthy community at the root of it, right? So I'd like to talk a little bit about not the sensationalist side of usurping parental rights, because I think that there's been a real mischaracterization of this bill in that way. I really want to talk about what happens to somebody when they get HIV, because I've been working in this field for almost a decade. I've worked one-on-one with clients who have been expelled from their homes. I have worked with Kanaka Maoli because as a Native Hawaiian, I'm very passionate about helping my community. And Native Hawaiians are disproportionately represented in HIV here in Hawaii, and up until very recently have been more likely than anyone else to be diagnosed with AIDS at the time of their HIV diagnosis, more than anyone else in the country. Which means that more often than not, they're coming to us from hospitals, from emergency rooms, when they're showing up and presenting with symptoms that are very severe and result in very poor health outcomes. Now, nowadays, that has changed because we've had community members who've risen up, but the overarching theme is that the people who've been impacted in this way have not been able to either, one, be open with their families, or two, have been expelled from their families because they were open about it. There is a significant concern for safety when it comes to families when it's related to HIV care because it's wrapped up in stigma around being LGBT. This bill does not take away the right of parents to talk to their children about HIV care, about STDs, and about healthy sexuality. Parents who are wanting to be involved in that way already are. This bill is for people who don't have parents who are that way. And for the vast majority, I think our parents do love their children very much, but there is a small group of people for whom that is not the case. I urge you to think about them when you're voting on this bill, and thank you very much for your time. Mahalo.
Thank you, Mr. Kealoha. And I did notice your testimony in the packet. We have testimony in opposition from Mr. Wallen Christian via Zoom. Not present. Members, we received numerous testimony in support and in opposition. We've also received testimony late support, again, in support and opposition. Any other testifiers in the room? Any testifiers via Zoom? Members, any questions? Seeing none, moving on to Senate Bill 2605. Okay, moving on to 2605. We are on the Reproductive Health Care Services Equity Act. Members, we have comments from DCCA Insurance Commissioner Gordon Ito.
Again, good morning. We stand on a written testimony offering comments. I'll be available to answer any questions.
Thank you. HMSA, Ms. Chris. Comments, Hawaii Association of Health Plans. Thank you. Planned Parenthood Alliance Advocates via Zoom in support.
Hi, my name is Rachel Kinsey again, and I'm the policy manager for Planned Parenthood Alliance Advocates. PPAA strongly supports the Reproductive Health Equity Act, which is a critical women's package bill aimed at fortifying the Affordable Care Act preventive services in state law and safeguarding equitable access to abortion care. Ultimately, while RIA's language may look long and confusing, the bill is largely keeping the status quo of current insurance mandates. What RIA is doing is protecting the people of Hawaii from the whims of the federal government and any potential changes to the state benchmark plan by codifying coverage for these preventive services in state law. Plus, RIA is crucially eliminating cost sharing for abortion, vasectomy, and PEP. Every service listed in RIA is already mandated under the Affordable Care Act and the state benchmark plan, with the exception of PEP. Since most of the Hawaii Prepaid Care Act plans are tied to the state benchmark plan, they are also already cover RIA's mandated services. And nearly all insurers approved under the Prepaid Care Act were already surveyed in the auditor's report. Not only do the insurance plans already require RIA's mandates, they also cover many of these services without cost sharing, with the exception of abortion, vasectomy, and PrEP. For these services, in the 2023 auditor's report, insurers confirmed that these cost-sharing provisions would likely have insignificant impacts on their budgets. While covering these costs will likely have little impact on insurers, RIA's no cost-sharing provisions will be indispensable to patients, who will benefit immensely from eliminating cost sharing. Notably, in other states that have eliminated similar cost sharing for these services, like Washington, Oregon, and California, the federal government has not determined these services to be new mandates. All people in Hawaii, regardless of income, wealth, or type of insurance, should have access to the full range of preventive sexual and reproductive health services at no cost. Thank you for your consideration and support for this important bill.
Thank you. We have testimony and support from the Hawaii Medical Association, support from AAUW of Hawaii, testimony and support from Indivisible Hawaii Healthcare Team, support from Save Medicaid Hawaii, in support Essential Access Health, in support Hawaii Academy of Family Physicians Legislative Committee. We have testimony in opposition via Zoom by Mr. Wallen Christian. Members, we also received testimony, late testimony from ACLU of Hawaii in support from Hawaii Democratic Women's Caucus, testimony from individual and in support and opposition, and I believe we might have received support, testimony from DLIR. Is DLIR here? DLIR, go ahead.
Good morning, Chair, committee members, Joanne Bidenhar from DLIR. We will have not submitted testimony, but what we will do is refer to DCCA's testimony. Thank you, and we're available for any questions.
Thank you. Any other late testifiers in the room? Any late testifiers via Zoom? Seeing none. Members,
Madam Chair?
Oh, go ahead. Go ahead.
Michael Glory Jr. for the Stonewall Caucus of the Democratic Party of Hawaii. We want to apologize for not getting our testimony in on time. We've submitted our written testimony in strong support of this bill. There's nothing more I could say that wasn't already said by Planned Parenthood for the reasons that this bill definitely needs to pass. And we do need this coverage. It will save lives. So we want to thank Planned Parenthood for their advocacy on this issue. We want to thank you for hearing this bill. We encourage you all to pass it out. Mahalo.
Thank you. Members, questions? Okay, I have questions. Insurance Commissioner Ito first. So thank you. We had an informational briefing that was very informative. It has been recorded. It was with members of your office, the Insurance Commissioner's office, DLIR, the Attorney General's office. And it really focused on the intersection of Prepaid Healthcare Act, the ERISA preemption that we have received following the enactment of the Prepaid Healthcare Act, the implementation of the Affordable Care Act, and some litigation, just some litigation that surrounds ACA. I urge members to take a look at that because this is a very serious area. And in previous discussions when we were implementing the marketplace and all of those things related to ACA, there was a lot of focus on the ERISA preemption. Can you explain the importance of that preemption to the Prepaid Healthcare Act?
So kind of the preemption or the exemption to the ERISA you're referring to. So, fortunately, back in 1974, the Hawaii Prepaid Healthcare Act was passed, which really provide for, it's an employer mandate to provide healthcare insurance for any employee working more than 20 hours. At the same time, in 1974, there was an exemption that was passed by Congress to exemption from ERISA to allow, prepaid healthcare act to continue. However, if there's substantive changes within the ERISA exemption, there's a language that says that if there's any substantive changes to the Prepaid Healthcare Act, the ERISA exemption could be lost, right? And so that's a very, serious thing that we always have to be mindful that we don't lose our ERISA exemption and therefore the Prepaid Healthcare Act authority or the exemption to exist. I must say that, and I said that at the briefing, that Hawaii, I think, are very, very fortunate to have the Prepaid Healthcare Act because, as I said many times, that, Hawaii has always been ranked number 1 or 2 as the healthiest state. And having healthcare coverage for people working more than 20 hours, I think it provides, a safeguard protection, not only in terms of potential financial disaster, but more importantly, it allows each and everyone who has coverage, healthcare coverage, really the opportunity to get healthcare services, right, without really thinking much about it. What I think a lot of people don't realize is that although our healthcare costs have been going up, healthcare premiums have been going up, and I've done many presentations about trying to bend the cost curve. It's important to also recognize that our premiums are relatively low compared to other states, and our benefit packages are extremely rich. The prepaid healthcare benefit is about a 90-10. Putting in ACA terms, that's a platinum level benefit package compared to the gold, silver, and bronze. That's 80-20, 70-30, and 60-40. So we're very fortunate to have the prepaid healthcare, and we have to be mindful of really preserving that and not violating the exemption language, to make some substantive changes.
So as it relates to this bill, which purports to ensure that we codify the essential health benefits from the ACA, in Prepaid Healthcare Act, there are a set of benefits that are required under prepaid healthcare.
Yeah, so
and you can comment on that.
So on the prepaid, how it works is there's what we call the prevalent plan, right? And the prevalent plan is determined annually as basically, according to prepaid, the most purchased plan. And we're very fortunate because our prevalent plan is really at for the most part, a 90-10 level, right? When you talk about ACA came in, started in 2010, but the essential health benefit started in 2014. ACA mandated that individual and small group plans contain 10 HBs. So the 10 HBs within ACA, I'll just quickly go through it, is ambulatory patient services, emergency services, hospitalization, maternity and newborn services, mental health and substance use disorder, prescription drug, rehabilitative and habilitative services, laboratory services, preventive and wellness services, and pediatric, oral, and vision. So those are the 10 HB that ACA mandates the plans contain for individual and small group. The difference between the 10 EHBs in ACA and our prevalent plan under prepaid is that there are 3 covered EHBs that are not within the prevalent plan services, and that's prescription drugs, habilitative services, and pediatric, dental, oral, and vision services. So those are the 10 additional benefits that are contained in the individual and small group plans that are not in our prevalent plan under prepaid.
Okay. Now, the list of essential health benefits that you just went through that's covered in the ACA does not necessarily match up with what's being in this, purported in this bill. And I think that's because these are tied to the prevalent plans and maybe more specific things in the prevalent plans. But I want to call out, is there, and I'm, again, is there abortion services identified as essential health benefits in the statute of the Affordable Care Act?
No, the abortion services is not contained within the 10 HBs.
Within the statute of the ACA?
ACA.
And
yeah.
I would assume also nothing regarding PrEP. And perhaps the PrEP requirement.
Yeah, so that's why in our testimony, in the beginning part, we note that, with respect to sections 2 to 7 within the bill, there might be benefits contained in the bill that are not part of the 10 HBs and that may be subject to what under ACA's additional benefits that were passed after 2014. Basically, 2014, when the EHB came into play, it locked in the 10 benefits. If the state adds on additional benefits that are not within the 10 HB, then the state may be subject to defrayment, where they would have to pay for the cost of additional benefits added beyond what is in the 10 HB and within our benchmark plan. So.
Okay, I want to come back to defrayment, but let's continue on with that. And just one more question, I think, around this EHB process or the essential health benefits. The other thing that you and your team explained is that the federal government has now initiated a process under which essential health benefits can be changed. And they're laying that process out. Can you briefly explain that and how the state might engage in that process so that we comply with ACA as well as fulfill what the policy recommendations are coming from the majority, from the legislature?
Yeah, so let's take, for example, the 10 HB for pediatric dental and vision. Though adult dental and vision services are not covered under the 10 HBs under ACA, right? And so many of our health plans do not provide for adult dental and vision. However, there's a process that is in play where the states have an opportunity to amend their HB and their benchmark plan. And so between now and if the state moves forward to trying to amend our 10 HB, if there's adult dental and vision coverage is provided for in the plans, and we adopt the plan as the benchmark plan, then the issue of defrayment may go away because it's included, and that becomes part of the 10 HB. So there's a process going forward in plan year 2020, I think 26, 27, that the state could potentially put this process in place to kind of basically redefine our 10 HBs. And that if it's within the state-defined 10 HBs, then the issue of defrayment goes away.
Okay, so we're looking at a timeline of 2025 and 2026.
Yeah.
Would it be safer to put it out to a finalized rule in 2027?
I think, yeah, it's 2027. I think there's still, we're waiting for the final rules from the federal government to come, to be adopted.
Okay.
And in part of the discussions, they had really talked about like adult dental and vision as potentially add-ons to the EHB.
Okay. Members, I've asked a lot of questions. Any further questions? Go ahead.
Can you, separate from the legislature, you yourself, ask or put into application these new benefits that would extend beyond 10 HB?
No, we don't have the authority to like mandate new benefits.
So you need this legislation in order to give you authority
This specific legislation?
Yes.
No, it's the process in terms of how do these benefits get incorporated to plans. So, and also, that's also going to be included in with respect to, in part, prepaid, right? Because the prevalent plan for small group would have to be amended.
Okay, thank you.
Thank you. Go ahead.
So I know that this proposed bill wouldn't have an impact on most people because these benefits are covered for most people. They would really have an impact on some union plans that were exempted from the ACA requirements that currently don't provide preventive health screening coverage for some, recommended CDC preventive cancer measures for women, for example. So I would like to see this happen. I would like to see those women get their coverage. Realistically, I understand that the chair is concerned about, unintended consequences of this bill. Realistically, do you think that is a possibility?
When you say possible in terms of the bill or the
No, in
benefit?
terms of this bill having unintended consequences for our prepaid Care Act and the defrayment, all that. Do you think that will actually happen, or is that?
Well, with respect to defrayment, I know that there are 2 states that had taken up the issue of defrayment and had actually, I believe, made payments on the defrayment issue. So it is a possibility that the federal government may come in and say, state by state, what other benefits are added that would be subject to defrayment. So it is out there because there are 2 states that have done that.
Thank you. Defrayment question was asked and answered. So there is a concern that defrayment could be an issue. Okay, any other questions for Insurance Commissioner? I believe I have questions for Planned Parenthood. So thank you for your advocacy on this measure. I have looked into the passage of RIA in Washington, Oregon, Illinois, and California. Can you explain to this committee what is the case Skyline Wesleyan Church versus California Department of Managed Healthcare?
I would need to refer back. I'm not familiar with that case, but I do know that 9 other states have passed no cost sharing for abortion services, and the federal government has not found that has created a new mandate such that it would require defrayal. I also want to address
No, I'm asking questions. So you don't know about Skyline Wesleyan Church versus California Department of Managed Healthcare?
I'm happy to follow up after this hearing with more information. I need to read into the case for more details.
What about Foothill Church versus Watanabe?
Again, I would love to follow up after this with specific case information.
Okay, I'm going to give you another list. Cedar Park Assembly of God of Kirkland, Washington versus Creedler and Inslee. Another bill I would like us to follow up on is litigation related to Fulton v. City of Philadelphia, 2021, a Supreme Court decision. And then a recent complaint filed in Oregon. I apologize, I don't have the name of that lawsuit, but I will provide that to you. And finally, Little Sisters of the Poor Saints Peter and Paul Home versus Pennsylvania, a Supreme Court case.
Yeah, I believe that one was around the contraceptive coverage mandate in the Affordable Care Act.
Okay, and exemptions, right? Potential exemptions around the contraceptive mandate.
Yes, exemptions to the list of preventive services, which is already required under the essential health benefits, or listed as one of the essential health benefits, which is required by both the Affordable Care Act and the Essential Health Benefits.
Okay.
The
Yes.
Prepaid Care Act is what I'm trying to say.
Wonderful. Okay, so I'd like you to follow up with this committee on those cases that are moving through the federal district courts, particularly in the Ninth Circuit, and looks like they might be even teed up for the Supreme Court. Okay, any other questions, members? Go ahead.
Sorry, one more for you. You've mentioned that there's 10 states that already enacted no cost sharing and there was no problem with the federal government. Can you tell me which states those were?
Sure. It's actually linked in the testimony that was submitted in written testimony. Some of them were mentioned, so Washington, Oregon, California, but there are more that passed this past year. And this was often states think of the AC as a floor, not a ceiling. Often states will go and implement state mandates that go above the Affordable Care Act. And I completely hear the concerns of this body in terms of worrying about the state needing to offset the costs. But as I said, no state, at least as far as reproductive health services, has found has been required to defray those costs. And even this year, Washington has actually implemented no cost sharing for PEP. This is fairly common in other states to expand no cost sharing for preventive services beyond what the Affordable Care Act requires.
One last question. Any other questions, members? My last question is, does any other state have employer-based health insurance in the way that Hawaii has?
No, my understanding is that the ERISA exemption is only for Hawaii. The intention of that was to require that, or to allow Hawaii to have broader protections than what ERISA had at the time when it was passed. So I would be, I would hope that it wouldn't cause Hawaii to not implement more preventive services and no cost sharing for patients when the intention of it was actually to be broader than what the Affordable Care Act required under the ERISA requirements. And I'm very grateful to this committee for considering all of the ways that eliminating cost sharing for abortion, vasectomy, and PEP would really impact patients' lives. I also wanted to say that I believe that state mandates would be more protective than increasing these benefits in a state benchmark plan, because those benefits would be required by state law and couldn't be impacted by what state plan is chosen in 2027. So for protection for the people of Hawaii, it is really critical to pass these protections in state law and not just leave it up to federal mandates and the preventive or the prevalent benchmark plan.
Okay, I really appreciate that, and I think that there's an opportunity for us to continue to collaborate on this legislation as we move forward with it, but I am very concerned because Hawaii is so unique. And that ERISA exemption or preemption clause was secured via an act of Congress. And through our great late Senator Inouye, to secure protections in this current landscape with Congress, I fear would not be possible. And so this does raise a great concern for myself and I think other members of this committee. But there is always compromise and there's always a way forward. So we will continue the conversation. Members, any other questions on this one? Okay, thank you. Moving on to Senate Bill 3000. This is relating to menstrual products. Members, we have testimony and support Department of Accounting and General Services. testimony and support from the judiciary, testimony and support from the Hawaii Civil Rights Commission, testimony and support from the Hawaii State Council on Developmental Disabilities in person. Thank you. Testimony and support from Kauai County Council Member. Council Member Addison Bulasan. Testimony from HMSA. Thank you. Testimony in support from Alliance for Period Supplies, Lacey Garrow. Testimony in support from IATSE 665. Thank you. Testimony in support from Healthy Mothers, Healthy Babies, Coalition of Hawaii. Testimony in support Zenden Midwifery. In support Midwives Alliance of Hawaii. In support Hawaii Health and Harm Reduction Center. Support Hawaii State Coalition Against Domestic Violence. In support Planned Parenthood Alliance Advocates. In support Ma'i Movement. Ms. Nikki Anyi.
Aloha, Chair Belatti, Vice Chair Takenouchi, and members of the committee. Mahalo for the opportunity to testify. I'm Nikki Ann Yee, co-founder of Ma'i Movement Hawaii. I stand on my written testimony in strong support to pass the measure as is. Access to period products is not merely a matter of convenience in state buildings and libraries. It is also a fundamental issue of equity of inclusion and equity of access to public facilities to everyone, regardless of socioeconomic status or gender identity. These places also serve some of our most vulnerable population. In the last 3 years, free period products have been made available by us and through our partner organizations. But we've also implemented programs in the DOE and pilots in universities, community colleges, libraries, courthouses, county facilities, and even in this very building. It is not about ideology or politics, but the actual need and problem that even state agencies recognize. When people and organizations ask us for help, and especially during the wildfires, we're always there to support, whether it's through products or education. I'm not here to ask the state to save us, but I am here to ask the state to recognize the issue of period poverty and menstrual inequity that affects people from all walks of life. Implementing this initiative is a matter of public health, equity, inclusivity, and equality. Mahalo for your leadership and the opportunity to testify.
Thank you. We have testimony in support from Period, Damaris Peretta, testimony in support Hawaii Women's Coalition, support Affirm Hawaii, Breastfeeding Hawaii in support Democratic Party of Hawaii, testimony in support via Zoom Stonewall Caucus of Democratic Party of Hawaii, and Rainbow Family 808.
Michael Goy Jr. For the Stonewall Caucus of the Democratic Party of Hawaii. Rainbow Family, that'd be my father, my 80-year-old father. He's in support of this, but I digress. Michael Glory Jr., Chair of the Stonewall Caucus of the Democratic Party of Hawaii. We stand in strong support of this. We thank the Ma'i movement for their leadership in this. We saw how passionate the Keiki were several years ago by getting period products in their schools. We are a firm believer, if you provide toilet paper, you need to provide menstrual products. And if cisgender men could bleed, that would already be the case. So we encourage you to pass this bill, make sure this happens, and it's an equity issue for us, and especially on the day after Equal Pay Day. What a wonderful way. Mahalo.
Thank you, Mr. Goluyu. We have testimony in support on Zoom by Chelsea McDonald. Go ahead, Ms. McDonald.
Hi, my name is Chelsea McDonough. I testify in support of State Trail 3000 because establishing wider access to free menstrual products would help ensure a more inclusive and equitable access to public facilities, reduce barriers faced by visitors to state buildings, meeting the basic needs, and promote greater menstrual equality in the state. Mahalo, and thank you for the opportunity to support this bill.
Thank you. We have testimony in opposition from Wallen Christian via Zoom.
Can you hear me?
Yes, Ms. Christian, I'm sorry. Ms. Christian?
No problem. Yeah, thank you. I oppose this bill not for the whole faction of it, but just for a portion of it. Having hygiene products for the people are great, but here's the problem. We are going to have damage is done, especially if it's done in public restrooms, any restrooms that is not monitored. And that will cost the people even more money because it will be a continual of repairing and replacing. As far as having the menstrual products in men's bathrooms, I myself don't believe that that needs to happen. Women restrooms, yes. I know we're going to have people saying, well, then that's going to be decisive and that's going to be discriminatory. I'm over 50. We've never had that issue prior having it in men's restrooms. But we have to really look at the cost of this for the people. And that's the problem. As far as in schools, when I went to school, you went to the health room and you got that if you needed it. I think that can continue. I think that's a great program for the kids. As for him being in public restrooms, I will strongly oppose that merely because of the cost of what it's going to cost the people and the government when they're going to have to replace and repair. Thank you for that.
Thank you, Ms. Christian. We have testimony in support from David Alexander Williamson via Zoom. Go ahead, Mr. Williamson.
Hi there. Making sure. Okay, perfect. Aloha from Na'alehu on Hawaii Island. I am passionately testifying on behalf of SB 3000, a significant bill aimed at mandating the Department of Accounting and General Services to supply menstrual products for free in each designated covered restroom of public buildings, including libraries catered to by the department. My appeal is for this bill to be passed in its current form. It holds immense socioeconomic value. By broadening the availability of complementary menstrual products, we contribute to a more inclusive, equitable access to public facilities. In doing so, we alleviate the obstacles encountered by folks visiting our public state buildings in fulfilling basic human needs, as well as fostering a heightened sense of menstrual equity within the state. This bill provides a distinctive chance for us to drive a significant shift and safeguard the dignity of girls, women, and all individuals who menstruate. Furthermore, it's important to illuminate the necessity of not only these items in female-designated and gender-neutral bathrooms, but also bathrooms that are designated for males. I'm referring to page 13 of the bill. We should remember our trans, gender-neutral, and Mahu friends who can experience menstruation. This inclusivity feature on the bill runs deeper than it appears, embedding the representation of those who carry multiple spirits within them. Acknowledging their existence and needs is a testament to many indigenous cultures before Western culture was dominated the masses. Ignorance about this issue is merely a throwback to oppressive colonial attitudes, which should be an aim for us all to surpass. Public restrooms have often been designed with only one demographic in mind, men. This oversight particularly extends to the lack of menstrual products in the restrooms, especially gender-neutral restrooms or restrooms for those who are menstruators, but also identify as male. Historical examples of this bias are the absence of changing tables in men's restrooms, another oversight that has only recently begun to be addressed. Utterly universal elements such as menstruation for far too long have been sidelined in the design of implementation of public facilities. Supporting SB 3000 stands as an important milestone in challenging these outdated norms and continuing the evolution of the public restroom. This will ensure that everyone's needs are met regardless of their body and gender identity. Bills like SB 3000 serve as powerful tools to dismantle androcentric restrictions, providing recognition and respect to the unique needs and experience of all menstruators. Such measures emphasize a fundamental truth. Access to equitable and dignified public facilities should not be seen as an earned privilege, but as an essential human right. In actuality, challenging deep-seated systems like colonialism and patriarchy isn't solely advantageous to women. The ripple effects stretch far and wide, shaping and influencing men and the broader society as well. The pushback against oppressive structures is fundamental in weaving a society that will be stitched with equality, where every thread, regardless of gender, race, or social standing, is interconnected in beautiful harmony. This rejection of patriarchal and colonial norms paves the way for inclusive growth, a kind of movement forward in society where no one is left in the shadows, silenced, or sidelined. Mahalo once again for allowing for me to have the opportunity to testify on this matter. Our collective support and efforts can lead to a more equitable future, where we can all play a part in ending period poverty.
Thank you, Mr. Williamson. Again, we have lots of testimony from individuals in support and opposition. We have received some late testimony. I do want to acknowledge that we have testimony in support from Gender Equity Movement, and then individuals in support and in opposition. Any other testifiers in the room? Any other testifiers via Zoom? Members, any questions? Seeing none. All right, moving on to Senate Bill 3239 relating to medical debt. We have testimony in support from State Health Planning and Development Agency. Testimony in support from Office of Wellness and Resilience. Testimony in support from Queens Health System. Thank you. Testimony in person from Healthcare Association of Hawaii in support. Okay, Tia, did you, Office of Wellness and Resilience, go ahead.
Sorry, thank you, Chair, Vice Chair, members of the committee. Tia Hartsock, Executive Director, Office of Wellness and Resilience. We stand in support of this bill looking at the authority of our office to engage in a program with this. We just received initial feedback from our quality of life survey that we've released, the workplace wellness survey, as well as the community quality of life survey, and have initial results around the medical debt question that we inserted for people who have a medical debt. And we're looking at about 12% of the general population having a medical debt of more than $10,000. It's 19% of state workers hold medical debt of $500 or more. These are just the initial survey results after this survey's been out for 2.5 weeks. So we're looking to get more data back on this issue and how it's applicable. We are looking at the fact that the authority of this office to be able to do this is timely due to the only nonprofit that we found that is able to do this work currently has a backlog as they're working with other states actively to implement these types of programs in their states with high rates of success. And so receiving the authority right now without state funds will allow us to tee up to be able to, when we're able to acquire state funds, when we're able to secure private funds to do this, to look at implementing this program and hopefully making a difference in the social determinants of health for residents of Hawaii. Mahalo.
Thank you. Thank you. Let's see. We have testimony in support Leukemia and Lymphoma Society, testimony in support American Cancer Society Cancer Action Network, in support Hawaii Health and Harm Reduction. We have testimony in support from individual Jackie Keefe and in support individual Will Karen. Go ahead, Dr. Lewin, in support.
Yeah, I'm going to say that, thank you, Madam Chair. I'm stating the obvious for all of you, but I think that if we can develop that universal access model, and we can, and we will, and to look at the affordability piece of that for all citizens in Hawaii, we could be similar to most of the other developed nations of the world, and we wouldn't have medical debt other than from, totally elective cosmetic procedures and so forth. So I think that's the goal we ought to be thinking about. We support this bill strongly. Thank you.
Thank you. Okay, members, any questions? So to the testifiers here, the practices of this committee is to defer decision-making to our 11:30 a.m. time slot. Go ahead, Representative.
For our Office of Wellness, what might be the cost of the program?
So there's no administrative cost to this program. The cost would be going directly to the debt relief, buying the debt relief from the healthcare systems. But administratively, we would contract out. It would not be us administering the program.
So how would you pay off the debt?
That would be done through...
Without state funds?
Sorry?
You said you would receive... This bill would allow you authority to implement the program without state funds.
Without state funds to administer it. The state funds would come as a contract fund in order to pay off the medical debt. So there would be state funds coming. That would be the request eventually. However, none of our office would take funds to administer it. It would just be contracted out. So there would be state funds to run the program, but we ourselves would not be requiring state funds to administer the program. We would contract the funds
So
out.
what would be the source of the money to pay down the debt?
So state funds could be, federal funds could be, private funds could be. So we're requesting authority right now, I believe the funding was taken out. But the authority to do so, looking at down the line, when state funds are available to implement this type of a program, that's what we're looking at. So the cost of that, looking at the other states, there is significant costs in implementing, contracting the program out to a nonprofit. So that's been done in several other states. But we're just asking for the authority in this bill.
But the authority then obligates the state for future costs.
Correct. Correct. It can also be private funds that are allocated. So other states use donations to acquire medical debt. They also have supplemental state funds.
Okay. Thank you.
Okay, thank you. Any other questions? Seeing none. Okay, so members, we are going to recess this to take up decision-making at 11:30 a.m. We are in recess, and then we're going to take a 1-minute little break.
protracted period it would take to accomplish this with no actual community services at the end of the road. We believe that repeal at this time is appropriate. We are very grateful that our collaborative efforts with the Department of Health and other agencies resulted in a lot of programs that were kind of triggered by this act. Even though the transition didn't occur, a lot of action did take place because of it. And Ms. Suji did indicate that some of those 3 programs that we have on our Leahi campus, 2 of which wouldn't have grown to the size that they've become absent Act 212. So we think that the act did serve its purpose, but to proceed with the transition, given the high costs and the time frame, we think that it's unnecessary at this time. So for those reasons, we support the repeal and support this bill.
Okay, we have testimony, thank you. Testimony and support from William Clayton Sam Park. Any other testifiers in the room? Any late testimony? Any testimony via Zoom? Members, questions? Any questions?
For Department of Health, please. Thank you. So can you please explain what the costs are?
So right now, we do not run any kind of long-term care facilities. So everything that goes into supporting that HHSC, the large corporation, takes care of would have to be transferred over to us. That would include contracts, software, management of the programs, and really, quite frankly, getting up to snuff on all of the skilled nursing facility rules and regs that we're not familiar with.
Thank you. Go ahead, Representative Takenouchi.
Sorry, on the for Oahu region, I guess on the flip side of that question, if the repeal does happen, is the intention to continue all these other services that HHSC started taking on?
Absolutely. So as I mentioned during my testimony, Act 212 kind of spurred us to really take action. In the testimony that we submitted, 2 main programs that we've expanded and created at the Leahi campus include, one is Palikana, right? And the other is a core program which just moved from Iwalei to the Leahi campus. Those are the main programs that take up all the rest of the usable space on the Leahi campus. So in the event that more space does open up, we have some dilapidated spaces that we're looking at renovating over the ensuing years. And when those spaces open up, of course, our plan would be to make those available, not just to the DOH, but any other agencies that can make use of it for either public services or possibly for revenue generation to augment our budget.
And I guess I would kind of hope that maybe as we could, last time I went to Leahi, if those spaces do become usable, I was kind of hoping maybe, when we talk about the need for long-term care beds to expand that program, which is like the original intent of Oahu region, correct?
Correct. So
is that going to be a priority if we're going to start talking about opening up these spaces? Or where's that balance, I guess, going to happen?
So there's a big challenge. So over the past, I think it was about 7 years ago where it started, CMS implemented new rules of participation for long-term care facilities. So it's not just state, but it's every long-term care facility. And these new rules are very strict in terms of how you're going to set up each bed for a long-term care facility. If you do any major renovations to a facility, then you're subject to specific limitations on, for example, the occupancy can only be 2 with the shared bathroom, other high requirements that we got grandfathered into with our existing beds. So if we were to build out these dilapidated spaces for additional long-term care beds, it might not be cost effective because of the requirements that are in place. And possibly, we're not sure yet, it might trigger us to trigger a loss of the grandfathering in for the other beds. And we don't want to risk that because we have numerous rooms that are occupied by 4 residents per room. Like the old school way of doing it was a quad room. But in our sister facility, Maluhia, we do have a unit that was closed years ago because of the reduction in force that we implemented in 2015. There's a big budget issue back then. but we're now in the process of reopening that entire unit for the specific purpose of long-term care. So there is a goal to address long-term care and expand it with that previously closed unit. It's just at Leahi, I think we're most likely going to have to use it for other purposes besides long-term care.
Okay, thank you.
Thank you.
Questions? I have a question, and it builds upon Vice Chair's questions. Existing beds under grandfathered rules, how many existing beds do we have? Sorry, I should have.
It's okay, it's okay. So we currently operate about 114 beds at Leahi specifically for long-term care. There would be more, but one of the units we've now dedicated to Hale Mohali, which is the third DOH program. We've moved them into the young building. And so of those 114 beds, I think each floor has about 30-something beds available. And of those 30-something beds per unit, I think like 5, so about 20 beds per floor. So it's a significant amount.
Okay, and then how many existing beds do we have under grandfathered rules at Maluhia?
Maluhia, it's not an issue of, I mean, it is a grandfathering issue, but there's no renovation that would trigger the loss of the grandfathering.
Okay,
right?
so again, then the question is, how many beds do you have at Maluhia?
At Maluhia, if we go to full capacity, if I'm not mistaken, I think it's about 158 beds.
Okay, so really, these 114 and 158 beds are the core services
That's correct.
of Oahu HHSC.
That and our adult day health programs at both facilities.
Your adult day health programs?
Yes.
Okay. Is there a possibility to expand your adult day health services?
It is possible, especially at Maluhia. We had some CIP projects that they're kind of in abeyance right now to expand the space available for the program. I mean, it's very popular. I think I'm not sure if we currently have a waiting list at Maluhia, but we did at one point. Leahi, we definitely can expand as well. But again, it's a matter of staffing, not just for our facilities, but all the long-term care facilities who offer similar services.
And then my understanding is adult day health services, those are actually more profitable lines of service, or can be, versus the residential treatment beds, long-term residential treatment beds.
It depends how it's
Structured.
correct, how it's structured. I mean, for us, not so much because we charge the Medicaid rate for the most part for the people who participate, and then the labor costs and other overhead exceed the revenues that we receive from it. So it's still, in a way, a safety net service for long-term care in the residential side and adult day health.
Okay. And then I had asked, and I really appreciate that in this interim time with the repeal hanging, or not the repeal, with the integration hanging over your heads, that you did take steps to look at innovative partnerships. My understanding is that through these innovative partnerships, you actually do get a revenue source that comes back to Oahu HHSC and gets plowed back into the core services.
That's correct.
Okay, and in the Palaikana project, how much in revenues do you get that gets plowed back into the services?
So I think I can break down to two different areas. On the one side, directly for the Oahu region, because it's a large space that is occupied by another entity, then there's reimbursements that we receive for electrical, the maintenance services we provide, some housekeeping services we provide, and just the use of the space. So I think that totals about $200,000 per year for the Palaikana side. With CORE moving in for similar costs, I think it amounts to about $160,000 per year. But I must say that for the Palaikana program, I think Ms. Tsuji can answer more about this, but AM HST did a study a number of years ago. And in that study, if they were to do a comparison of people who are AM HST patients and they would be housed at the higher cost facilities, whether it be Hawaii State Hospital or the other intermediary facilities, versus at Palaikana, the savings in 1 year was up to like $15 million. So it won't show up on our balance sheet, but it's the savings to the state.
Yeah, and that's the issue of the savings to HSH.
Correct.
And the AMHD budget.
Correct.
Okay. Now, because of the partnership with the Daniel Keakaka State Veterans Home, there is also an expectation that there will be revenues from that plowed back into Oahu region that will then be able to help support our long-term care beds, which is, again, the core services of Oahu. Can you speak to what those projections are going to be?
Certainly. So, again, I have to preface this by saying these are very crude estimates, and they were done, I think, initially when the facility was first contemplated. But then I think in 2021, I thought it was earlier, but in 2021 they did a survey projecting if you had certain assumptions made of occupancy, that the revenues would total X amount, net revenues. So I think in the first year of full operation, you have to understand that we have to get certifications from CMS. We have to get the VA certification as well. So the occupancy will be very low as we go through that process. But assuming I think about 17% occupancy rate in the first year, it would result in a loss of about $780,000 in the first year. But then if you up the census to about 60-something percent, 68, 69% in the second year, then we're looking at a net revenue stream of, I think, about $4 million. And then if you go to the next level where you have a 90-something percent occupancy rate, then the net revenues are anticipated to be about $6 million. Of course, in the beginning stages of the project, we're going to be taking out lines of credit to fund things so that we're not coming to the legislature for funding initial capital, startup costs, initial staffing, construction, deficiencies that weren't contemplated before. All of these things will be covered by a line of credit. So when we do reach that point of positive net revenue, then we're going to use that to pay back all of the loans. That should take some time. We also have the land is owned by HHFDC. So we have an arrangement with them where part of that net revenues, once we are in the black, will have to be shared with them. But I mean, this is a large amount of revenues, net revenues that we anticipate receiving in subsequent years. So the projections would be loss first year, about 800,000, then 4 million, then 6 million, which should be static, indefinitely after that, if the projections are correct. And I would say that they are very crude estimates based on certain major assumptions.
Is there opportunity to revisit, because the revenues are based upon an operating agreement that you have with the people who are going to be running the state veterans homes, correct?
That's correct.
Is there a renegotiation period so that you can revisit revenue sharing? I think the fact that it's land, precious land,
right,
that is allowing, one, it's providing a service, but it is also allowing a for-profit company to make, or nonprofit, but it is allowing some profit made, that there could be more profit sharing with the state entities?
There could be, but the way that it would materialize would be a renegotiation of the management fee that we pay to the operator. So our initial agreement goes for about 5 years. So when that 5-year period is coming up for renewal, then that would be a renegotiation period with the operator. In terms of our relationship with HHFDC, that's, I think, under a 100-year lease. So that will remain pretty static.
Okay, but we could see potential, because we're going to have faith that you're a great negotiator, Mr. Sonata, that
we'll try our best.
You could renegotiate.
We could.
And there's always an opportunity to do that renegotiation.
That's true. Correct.
Okay, wonderful. Thank you. Question, go ahead.
From Mr. Sonata. So I used to work at Leahi, and when the UH programs left, the HIV research program and TropMed left, did you folks use that space, or is that considered unusable space because it was all labs, clinic, and office?
So the spaces that were office are now offices that we utilize, but the lab spaces, hazmat issues, there's a lot of disrepair. Those generally fall into the dilapidated areas that are not usable, but are now being considered for renovation and reuse. But it's fallen into such a state of disrepair over the years because there was no focus on fixing up the spaces with CIP funds, but we're moving in a new direction now to actually address those issues.
Thank you. Members, any further questions? Seeing none. Thank you, Mr. Sonata. I know you're going to be back up here, so we will move to our next bill, Senate Bill 2837. We have testimony and support from State of Hawaii Department of Defense. Mr. Oliveira. And if you have a title, I apologize for not using your title.
No problem.
Brigadier General, I see it.
I'm retired. So good morning, Chair, Vice Chair, committee members. Bruce Oliveira. I'm the interim director for the Office of Veteran Services. Just to summarize my testimony, the purpose of this act is to transfer the Maui State Veterans Home to the Oahu Regional Healthcare System or another state agency. I stand by my submitted written testimony. I do have copies to provide of, if required, of potential sites for the where we're looking at on Maui for the state home, and also some proposed language for the act from the AG's office. And with that, I thank you for the opportunity to provide this testimony in support of Senate Bill 2837 SD2, and will be available for questions.
Brigadier General, if you could provide that information to the committee clerk, and we'll make sure that all the members get it.
Absolutely.
It would be very helpful, actually. And we'll move on to the next questioner, and I'm sure there will be questions.
Okay.
The next testifier in support, Hawaii Health Systems Corporation.
Good morning again, Chair, Vice Chair, members of the committee. Edward Chu, President and Chief Executive Officer for HHSC. We'll stand on our written testimony supporting the intent of the bill. We believe having a Maui Veterans Home would be a good thing for the veterans that are living there, and would help support the provision of long-term care services in the state of Hawaii. So thank you very much.
Thank you, Mr. Chu. Testimony in support, Oahu Region, Mr. Sanada.
Morning, Chair, Vice Chair, committee members, Sean Sanada on behalf of the Oahu Region. Likewise, we stand in our written testimony in support. Just emphasize that we support this facility. That's all it is, whether it be us or another agency that will be responsible for it ultimately. We just want it to happen, and we think it's important for the people of Maui.
Wonderful. We have testimony in opposition from Hawaii Government Employee Association. Testimony in support from Mr. Tom Driscoll, who I see present.
Chair, Vice Chair, members, Tom Driscoll, Hawaii Office of Veteran Services. Big Island's got a state veterans home for our veterans. Oahu's opening one for our veterans. We need a state veterans home for our Maui veterans. 3 years ago, we found ourselves in a situation where Department of Defense with DAGS was building the Kapolei facility, did not have the authority to operate that facility. Thank you to the legislature for intervening. Thank you to Oahu Region for stepping up to the plate. We now have a proper state agency overseeing the operation. We don't want to find ourselves in that situation again. This bill paves the way by creating proper authority, be it a Oahu Region or any region of HHSC, to oversee this facility. This facility will create jobs. It'll create new training alternatives and options for Maui High School and Maui College. It'll bring in new federal funds for the county of Maui, and it will help alleviate the long-term care waitlist situation for Maui Memorial Hospital by creating extra long-term care beds. We feel this is great for our veterans and wonderful for Maui County. It'll be a big boost. I hope that you can see your way clear to pass this on so we can pursue this worthy project for our veterans. Thank you very much. Be available for questions.
Thank you, Mr. Driscoll. We have testimony in support from Kathleen McNamara and testimony in support from William Clayton Sam Park. Testimony in support from R. Maui Cuizon, retired sergeant. Any other testifiers in the room? Any other testifiers via Zoom? Seeing none, members, questions?
HHSC. So since we last heard this bill, has there been any movement on, re-engaging the Maui board aspect of, or getting, like beefing them or getting them back involved, or has there been any movement on that?
I believe, that would be a question more for the Maui Region Board Chair, who's Avery Chumbley. I thought he had submitted testimony on this bill as well, but maybe he didn't. At this point, the issue with Maui Region remains the same. They are a self-perpetuating board, so it's not like HHSC is involved. That board has to, if it's going to reinstate itself, then it needs to have members on the board to officially operate. By statute, that is 6 members. They right now, I believe, have 2 members that are on the board. So until they find another 4 members at minimum to be on that board, then they wouldn't be able to be the entity to operate the Veterans Home.
Okay, but, oh, so there is some work that, because you thought they were going to submit testimony, they maybe just weren't ready to, but, so there's some movement, like, they're aware that.
They're aware of the situation, and I think they do, from what I understand, I believe there is some support there for the veterans home idea, for sure.
Thank you.
You can stay there. I have a follow-up question. I would greatly urge that if this bill moves forward, that they need to be a part of this conversation as the board members. So please communicate that. Also, we just heard testimony in the previous bill that there are revenues to be shared, and I am sensitive that revenues should go back to the Maui health system. And so we need to ensure that. And I appreciate the language from the AGs because it sets the stage for that, but I want it to be certain.
Yes.
I want it to be certain that the money from Maui goes back to Maui. Yes. Also, this raises an issue with the relationship between this Maui board that should have actually continued to be active in relationship with Maui health systems. And what are it should be, there's supposed to be some kind of community engagement, and we can revisit that because it raises questions, right? Like with the privatization effort or the partnership effort.
Yes.
Can you comment on that?
Yeah, so, one of the duties of the Maui Regional Board was they had the ability to recommend 3 members to the Maui Health Systems Board. And Maui Health Systems is the affiliate of Kaiser that is running the 3 hospitals right now, Maui Memorial, Kula Hospital, and Lanai Community Hospital. So those 3 members are still there. So they are participating in terms of, providing input on the Maui Health Systems Board for those operations. So that is happening.
Who are those 3 members?
I believe one is Tony Takitani, one is Clay Sutherland, and the third name is escaping me at this point, but I can provide you the other name.
Helpful.
Yeah. But those are the 3 members that are currently serving on the Maui Health Systems Board. Should the Maui Regional Board be able to reconstitute itself to potentially operate a Maui Veterans Home, they would have custodial control over the assets and liabilities for the region, and if that includes the Veterans Home, they would also have control over that as well. So that would help, support the idea of the Maui, whatever savings or revenue that come in from operation of the Veterans Home would stay in Maui.
Okay, all right. I think it's really important. I mean, I know the regions act very independently, but I think in this instance, we need to make sure that the reconstitution is happening.
Yes.
And that follow-up for Maui region is directed by Maui folks.
Yes.
And that's really important. Representative Kobayashi.
Well, I'm not too sure that I agree about who should manage and control this Maui Veterans Home. I think the Maui Board might be a good way of providing advisory input. But if the Maui Veterans Home is to be operated by Oahu Region, I think the operator should be fully in control, not have another body who's not the operator be an advisor and a policymaker.
Well, our testimony basically stated that we are in support of the intent of having the Maui Veterans Home. If the Maui Region Board were to be reconstituted and active, that would be the most appropriate place. But Oahu Region has stepped up in the sense of they'll be willing to be able to run it if that Maui Regional Board is not able to do it. So it's just to be able to get the process started so that they can get DOD can get the funding to build the home. So it's not like we're like saying we definitely want to run it. It's more of a sense of we want to help get this project started. If you need a state entity to be the one to start the ball rolling to get the federal funds and the state funds going, then we'll be able to do that. But the best place we understand is to be a Maui Region decision.
Thank you.
Just a clarifying question. When Oahu, and maybe this is for Sean, Mr. Sanada, if Mr. Sanada can come up, even though you are overseeing the operating management with Ohana or the new operator, you're not making policy calls on the running of the of the state veterans homes. So I just want to clarify, because I think what I heard Representative Kobayashi says is that there's a concern that there might be policymaking powers by the regional board. That's not happening. The authority is you guys sign that authority over to the operator.
Correct. For the most part, we sign the authority to run the operations to the operator, but the part where the administration with the Oahu region and the board gets involved is in the initial framing of how the operations will take place. I'll just make it simple. In our agreement with the current operator, we've in our agreement set forth certain performance metrics that they have to meet in order to ensure that the quality of care for the veterans is very high. In the event that they are not able to meet these standards, then it's a financial penalty against them. So there are specific penalties that are incurred by the operator if you do not reach that high standard of care. So where we get involved is first setting what those standards are, selecting the operator, but then in the long term, it's just about monitoring their performance to make sure that they're meeting the metrics and ensuring that we don't have to penalize them.
Does that address some of your concerns, Representative Kobayashi, or does that add to your concerns?
It does add to my concerns. Yeah, thank you.
All right, thank you. Thank you for the explanation. Members, any other questions? All right, members, on these two measures, Chair's recommendation is going to be to defer this to decision-making tomorrow at the 11:30 a.m. Timeframe in this room. I want to thank Chair Martin for allowing me to be able to use that room. There's a lot of moving pieces to this, and we want to make sure we get the language right. So we're going to defer decision-making to these two measures to 11:30 a.m. tomorrow in this room, and that will allow us to meet the deadlines. All right, so we are adjourned on this one at this time. Members, moving to our 10:30 a.m. agenda, one bill, Senate Bill 3139, relating to crisis services. This is to expand existing services for mental health crises. We have testimony in support from Department of Law Enforcement.
Chairs, vice chairs, members of the committee. My name is Michael Vince. I'm Deputy Director of the Department of Law Enforcement. The Department supports this measure. There's a number of bills moving through the legislature this year regarding behavioral health issues, and this is one of them. There's a similar bill that Senate Bill 2345 that's also being heard sometime this week, I believe. Our testimony is in support. We're recommending a couple minor additions to actually bring it in line with Senate Bill 2345 that would allow a law enforcement officer, trained crisis intervention officer, to actually be called on scene for somebody in crisis and make the call to take the individual and have them transported to a behavioral health crisis center. Currently, law enforcement officers have limited options. They can call a mental health emergency worker to come on scene and work with the individual, and they make the decision on whether or not to refer them for a psychiatric facility or, in this bill, a behavioral health crisis center, or arrest the individual or leave them on the street. So the language that we're proposing would allow trained law enforcement officers that are trained to be crisis intervention officers to actually be able to make the call to have them transported to a behavioral health crisis center where they can be evaluated by professionals and given the proper care and help that they need. That was all that we have for, if you have any questions, I'll be around. Thank you very much.
Thank you, Deputy Director. All right, we have testimony in support judiciary. Testimony in support the Institute for Human Services. Testimony in support Queens Health System.
Chair Bellotti, members of the committee, J.C. Mikulak on behalf of Queens Health System. Just standing on our testimony in very strong support of this measure and investment in this and the crisis care that's needed in our state. As you know, our Mana Mana emergency room is one of the busiest in the state of Hawaii. So having spaces to decant and place folks that are in crisis outside of the ED is critical, as well as investing in the entire continuum of care. And we do believe that using the mental health emergency workers is also critical because they have that clinical experience. So we want to emphasize that. Thank you.
Thank you, Mr. Mikulinek. Testimony in support, Aloha Care. Testimony in support, Hawaii Medical Association. Testimony in support, Hawaii Psychological Association. In support, Hawaii Substance Abuse Coalition. Support, Opportunity Youth Action Hawaii. In support, Hawaii Disability Rights Center. Community Alliance on Prisons, in support, Ms. Brady.
Good morning, chairs and vice chairs and members of the committees. Kat Brady testifying on behalf of Community Alliance on Prisons in strong support of this measure. We witness this every day. We know the need is so great for behavioral health centers. At a recent hearing, Dr. Luke of the Hawaii State Hospital said only about 30% of the people who are there actually need to be there. And for $1,000 a day plus to put them there, I think we should give appropriate care to the people and actually be mindful of the costs, because sticking somebody in the Hawaii State Hospital is not, I think we really need stabilization centers. We need a collaborative approach of many different disciplines that can actually deal with so many issues that people who are living on the street or people who are coming out of prison or just members of our community need. So I really hope that you support this bill and others like it. Thank you.
Thanks, Ms. Brady. Testimony and support from Christopher Fernandez.
Good morning, Chair Chair Bellotti and Chair Martin and members of the committees. I just wanted to note that I'm here in my personal capacities today for this bill, and I support the bill. In 2008, I moved from a small rural town of about 3,000 people in Northern California to San Francisco to work on a master's at San Francisco State University. I had worked for years in a mom and pop manufacturing shop and wasn't really prepared for the urban job market. It just so happened I found a work at a nonprofit agency that contracted with the city, county of San Francisco, as well as the state, that provided client-centered residential treatment to those with mental health illness and crisis. The agency adheres to what it calls the 5 principles of social rehabilitation, which I've included in the written testimony. I see that it was entered late, so I apologize. The principles in the agency's approach to mental health care were created to emphasize dignity in mental health illness care at a time when there really was not a lot. And at the time where deinstitutionalization left communities without any systems to deal with its effects. Excuse me. One of the agency's achievements was to establish one single acute diversion unit, or ADU, in the heart of the Mission District, blocks from San Francisco General. The idea, divert people who would otherwise be turned away or admitted into the hospital to a 2-week ADU, as they were called, in order to stabilize from their crisis or crises and to connect or reconnect with their mental health outpatient services. It was a success, and several other ADUs were placed throughout the city, all diverting people from the hospital stays. This began, the company began about 1969. In 2008, an additional ADU and clinic that were together were opened, and the role of the clinic was to act as an alternative to psychiatric services at SF General and other hospitals in the city, where people could self-present, get immediate stabilizing mental health care, or get help with interfacing with law enforcement or emergency services who would need to take the person to a higher level of care due to additional factors such as the inability to ambulate. The system worked well, but it did have growing pains, which were exacerbated by funding limitations. The agency forewent fundraising as an economic source to pay for the consistent income that could be utilized for care. It instead went the county and state avenue. I support the DOH's intent to expanding its services with this program, so long as the treatment provided does not mimic hospital care, rather provides an alternative community-based approach that prepares people for getting help and getting back out on their own with support if needed. Thank you.
Thank you, Mr. Fernandez. All right, we have support from Lillian Harwood Ossing, support from Carolyn Eaton. Any other late testimony? I believe we have testimony from Department of Health. Department of Health, thank you. Sorry.
Chair Bellotti, Chair Martin. I apologize for the late testimony. Department of Health stands strongly behind this bill with relatively minor amendments listed in the written testimony. We'll be here for questions.
Thank you. We have testimony from State Council on Mental Health. Okay. Any other testifiers in the room? Any other testifiers via Zoom? Members, questions? Question, go ahead, Representative.
For DOH, is the 6.7 million for this year or next year?
It's for next year. So this
Next year.
this current fiscal year is utilizing some ARPA funds and DOH budget.
Thank you.
I have a question, Dr. Koyanagi. Do you know if there's any more additional ARPA funds that are available that can be utilized?
No.
And then there are funds in the Mental Health Substance Abuse Special Fund. The last time I checked, there was like maybe $9 million. Is that also additionally could be used? Okay, maybe the Director Suji, Deputy Director Suji.
Correct. We have money in that special fund, and we utilize that for group homes, as well as for other things that we don't get funding for. It goes right back into the programs.
Okay. Members, any other questions? I have a question. So can we get a quick update, because you folks opened, a behavioral health crisis center a week ago. Was it a week ago?
Yeah.
How has it been going so far? And I understand, like this. I mean, this is part of that funding that you're being requesting for. So how has that rollout gone? Even just a week.
So we had a soft opening Friday morning at 7 a.m. Soft because we're opening slowly due to need for continued construction and proper licensure. So as of right now, we have 20 through 59 observation beds. We aggressively notified our community partners, including the law enforcement and MHEWs and the CARES line, that we're looking for people to be brought to our facility. So over the weekend, there were a couple that were brought in by crisis mobile outreach workers. They were successfully transitioned onto stabilization beds after the 2359 stay. From what all accounts, both clients had positive experiences. And so we're in a daily dialogue with Care Hawaii, who's running the facility, as well as law enforcement, to see what we can do to encourage more referrals and to consider broadening criteria to accept patients as the days go by.
Okay. I know in that area, and I don't think we have anyone from IHS here, but in that area, they have a similar program that's not, it's not called a Behavioral Health Crisis Center. It's a detox center. It's funded by an ADAD contract. Does that potentially become part of this network where, if we were to get up to speed with these mental health emergency workers, as well as the CIT trained officers, is that facility potentially a part of the area that can be where folks could be diverted to?
That particular facility, I believe, is primarily a detox facility, not a crisis facility per se. So MH1s could not be brought there by statute. Our facility, we're a crisis center, and if someone is brought to us in crisis, we could also accomplish the detox goals if that's part of the individual's recovery plan.
Is there any sense that there could be behavioral health centers that are stood up, like, that are run by an entity like IHS?
Given the, you mean procured on their own and?
So, yes, for example, so if you were to create behavioral health crisis centers, and then, I mean, IHS could be the operator in a facility.
Yeah, so.
If they wanted to contract that.
So the process for, we had the RFP, which any appropriate agency could have bid for, and it could have been IHS, or subsequent ones are going to be the same kind of process with RFP, and they could bid to be the operators of those subsequent facilities.
Okay. Do you know if there are other entities out there that would be willing to be licensed as behavioral health crisis centers? And what is the licensure that you say that you're going after?
So we have to complete the construction work in order for the specialized treatment facility to have the 2359 floor, as well as the observation, extended observation beds upstairs. The other part of the question, so based on, there were multiple bidders for the contract to run this first one, and I imagine there will be more than multiple agencies that would potentially be interested in bidding on any further BHCCs.
One last question, again, just what is the specialized license that is needed for the Behavioral Health Crisis Center?
It's a license through OCA, and because we will be having a padded room built into that facility, and that means restraints, we have to have that license.
Okay, and OCA is?
Office of
Healthcare Assurance.
Healthcare Assurance.
And those have federal mandates around that, or what?
They've got some federal mandates, and they've got their own rules.
Okay, and this is rules set up by a state agency?
Yes. DOH, in fact.
Okay, all right.
And can I, just one more
Go
comment? So
ahead.
the most BHCCs have a seclusion restraint room, not to scare anyone who might want to come there, but it's a very last resort, and hopefully a very rare occasion that we'll need to use the seclusion restraint room.
No, this is for folks in crisis, so we understand that. Okay. Question?
Mr. Kuranagi, sorry. We do have, Chair Bellotti brought up this, the IHS triage and rehab center, and we do have a bill still moving that started out as another one of those and is now a working group within the governor's homeless division to look at that type of system. How would that connect to these crisis centers? Like, what would the relationship be, if any?
So certainly we would be happy to collaborate with all of the community partners, especially the ones in Evelay area. The main difference is with the detox center, it's a voluntary place where people get brought to. Again, you can't bring MH1s there. So there may be people who are in crisis, who either are denied MH1s or through some other referral process get referred there instead of our place. But our place would be for voluntary and involuntary patients, and we also have med management detox capability too.
But would you see, like, if you folks are full, would you refer, like, transfer patients there? Or, I mean, I'm just trying to think how the two systems could be linked.
So if we were full and we were brought someone who was willing to go there voluntarily and had met their clinical criteria for admission, then we would call them and see if they would accept the patient.
Thank you, Chair, and I apologize, as officer is coming up. This is a joint Health and Human Services hearing.
Right, so my apologies. I actually had some testimony, didn't make the cutoff, but I do apologize. But thank you, chairs, vice chairs. So some of the questions is connectivity to the BHEC, and then the bigger picture, I think, is what you guys are trying to see, where does it fit in? So the goal would be is to have centers that don't need the type of care that a hospital provides, but still has a wraparound services for someone in crisis. So how that would connect to something like Connie's program for her detox is that if somebody was brought into the BHEC, whether involuntarily or not, once they're assessed and they get down to a place where perhaps they are now in a voluntary space and would need additional detox services, then they could be routed. From that BHEC, it can basically go any direction. It can go back up. They could be brought into the BHEC and then require an actual psychiatric facility, or they could be doled out right to shelter or right to a detox. So it's kind of that middle piece that hasn't been there. So we kind of have like all or nothings right now, where it's like, you know, you got your emergency room and then you got shelter, and then we have some slow pieces turning on like Connie's project. So BHEC would kind of be that intermediary project, and I think it's something that's very needed. And that's why for the Honolulu Police Department, we deal with the people in crisis, and we want to have that intermediary where if we are able to de-escalate someone without overburdening the emergency room, we can have that other service, and then they can make an appropriate determination where they should go from there. So thank you.
Actually, can you stay up there?
Sure.
Because this training is an important piece of it.
Absolutely.
And I know that in the testimony from DLE, they're asking us to insert crisis intervention trained officers.
Correct.
How many crisis intervene trained officers do you have now at HPD?
So right now we have over 200 crisis intervention team, which is a 40-hour training. It's from a national agency, Crisis Intervention Team International. They are considered the gold standard for law enforcement and understanding people in crisis. And then we have about 288 officers that get the 8-hour very basic mental health first aid training. So since 2022, every officer that graduates the Honolulu Police Department graduate mental health first aid certified, and we're very proud of that. And again, the reason why we're asking to support language provided by the Department of Law Enforcement is that I agree that in 2008 or so, when MHEW, that process was created, law enforcement and particularly the Honolulu Police Department didn't place a lot of effort on mental health training, and it was very appropriate for us to utilize a clinician for every call. I think fast forward 16 years and our investment into these mental health trainings, officers could have the ability to go ahead and recognize someone in crisis and place them somewhere appropriately. And when I say this, I want to provide my apologies to the clinicians that perhaps sometimes feel like they went through so much school to make that determination, and for an officer to have it so readily could be offensive. But the issue is that when we get to the scene, it's 5 to 10 minutes for us to even de-escalate someone to make that call. And then once we make that call, it's 5 to 10 minutes to gain an approval. So someone's access to care can be delayed anywhere from 10 to 20 minutes, and that's under optimal conditions. So what we want to have is that ability to quickly recognize someone is in need of crisis services and get them there quickly. When it's generally a mental health crisis, isolated mental health crisis, delay is not too critical, but once you overlay drug utilization where they could be overdosing in front of us, that 10 to 20 minutes, we could have someone expire with us. And again, it doesn't fall on MHEWs, it doesn't fall on anyone else but the Honolulu Police Department. So, you know, my apologies to the clinicians for fighting for this, but it's a huge liability for our department. And again, it's about access to service for someone in crisis.
I think, go ahead. No.
I just had a question. I know that in my community, the people that would likely be called for an MH1 are very well known to the local police officers.
Sure.
And with that institutional knowledge of their history, their background, would those records be available to these officers that are seeing them at that moment? Do you folks have, access to that information?
We do. So what we do track in the Honolulu Police Department is we do have the amount of times that someone was MH1 for mental health evaluation. So we would have that data. So we say this is the 6th time or 8th or whatnot. And we're actually working very closely with our partners at Department of Health to work, and with Connie and others from IHS, to make sure that assisted community treatment is a pathway. One of the things we're working on is information sharing, because in that application, what we want to do is ensure that the courts can see the impact on the community, and then having the officers to attest to the amount of calls, the amount of interactions, and the condition of that person we feel can really help in those type of assisted community treatment petitions. So we are aware, and the biggest point that we want to make is that we do want to divert people away from jail when perhaps crisis systems are probably better suited for them.
Can I ask a question on the training?
Mhm.
So I am sensitive to the issue of how to make the call and who gets
Sure.
to make the call. Is there any other additional level of training that's available to law enforcement nationally that could bolster the 40 hours of training annually? So is there another level? Is there another
I'm not aware of one, and that's why for me, there's over 35 states that don't require it, right, for an officer to have additional training. And I think in the Ninth Circuit, only Oregon requires an intermediary to make that decision. So most states trust their law enforcement to make that call. What I don't want to do is have the pendulum swing all the way back to what it was pre-2008. So pre-2008, again, we didn't make an investment in this, and we were probably making poor referrals. Right, so I don't want that. So I don't want it to swing all the way back. What I want to do is kind of meet in the middle to say, okay, only officers that have received a 40-hour training, and then what we want to do is work with the DLE to create a test, an aptitude test that shows that they have a competency in making that determination. So it's not like you go to the class and then you're good to go. It's you have to take a test to show competency in 334-59, as well as the observations required to meet that standard, and then they would be signed off. So that's why it would be a transition period. So by no means do we want to get rid of the MHEW. We want them to be more of a support service versus something that we have to gain their approval. So for example, in situations where it's non-confrontational, calling an MHEW is no big deal, right? Or in situations where they're not physically combative, it's just the thoughts in their head are very dangerous. For us, the issue and why we're pushing for it is we don't always get those type of kind calls. They're running through the streets, they're actively violent, and then having to call someone is just not practical. So we should be able to have that. And again, if the legislature defines it as a very narrow window, but beyond threatening or attempting suicide, which is the only situation we don't need to use MHEW, that's also something we'd like to entertain.
Okay, that is an important piece that I think we need to come back to. And so let's continue this conversation. But any more questions, members? Okay, seeing none. Members, on this bill, oh, actually I do. Dr. Koyanagi's not here.
No,
Okay,
I just
Dr. Koyanagi. Oh, I think I had a question, and it's about timing. I think it's about timing. As you folks roll out this BHCC and EVALA, what is your sense that you guys are going to ramp up and see more referrals beyond what you guys have limited it to? I think it's only suicide only. Suicidal calls only.
And once through the CARES line and crisis mobile outreach. So the two key issues that we need to resolve are one is the licensure, and the other is the change in the statute, which would allow any MH1s to go to our facility, go to a BHCC instead of a ER. So once those two things are accomplished, then we'll be good to go on a much larger scale.
So this legislation is critical, that allows for the transfer to the other facility?
Yes.
Okay, and then, so the licensure, what's the timeline on the licensure?
So we're going, we have to get, the licensure is dependent on completing the construction first. And unfortunately, we have some things we can't control regarding materials being sent over from mainland, which are necessary for the specialized seclusion restraint room.
We've gone through this over before. How is the operational side of the crisis center working out with coordinating with, the existing structure where Queens is called and then they make the call? How is it? Is that working out?
So we have almost daily, or several times a day, communication between DOH, Care Hawaii, and MHEW program, and then as needed, communication with law enforcement. So it's going well, and we're also, of course, collecting data to show that the cost benefits of this program for next year.
Okay, and so the operational procedures, even as we're waiting, are being mapped out?
We have standing meetings with Care Hawaii and MHEW program to make sure that things are going smoothly, where we can improve the inflow of patients and any other modifications we need to make to our program or our specifications.
Thank you. I know this is hard work, but this is work that I know a lot of folks are committed to, so I appreciate it. Thank you. Members, any other questions? All right, members, on this one, also because there's just a lot of moving pieces and we have some amendments that we want to kind of closely take a look at and align with other bills that are moving, we're going to defer this to the 11:30 a.m. hearing, decision-making agenda for tomorrow in this room. Is that okay? All right. So on that note, we are adjourned and we will be coming back at 11:30 for our 9 a.m. agendas, members. We are adjourned. Reconvening our 9 a.m. health agenda for Committee on Health and Homelessness. Members, we're taking up Senate Bill 2556 first, relating to Community Outreach Court. Chair's recommendation is to move this out with a HD1 and a defective date of 3,000, our standard 3,000 defective date. Questions, comments, or concerns?
Comment.
Go ahead.
In the committee report, maybe the $250,000 for Department Law Enforcement should be reflected to give finance notice.
Okay, we will insert that, and then if we are able to determine what the money amounts also are for the other appropriations, we will also put those in there as well. Okay? Any other comments, questions, or concerns? Seeing none, Vice Chair for the vote.
Voting on SB 2556, ST2, Chair's recommendations passed with amendments. Chair and Vice Chair vote aye. Representative Amato?
Aye.
Representative Iligan?
Aye.
Representative Kobayashi?
Aye.
Representative Martin?
Aye.
Representative Nishimoto is excused. Representative Garcia?
Aye.
Chair, recommendations adopted.
All right, members, moving to SB 3129, SD2, relating to health, the Hui Ho'omana Task Force. Chair's recommendation is to defer this to 11:30 a.m. tomorrow when we take up the other SHIP-D bill. Also, that was on this 11:30 a.m. agenda for today. Members, questions, comments, or concerns? Members, moving to Senate Bill 2682 relating to lead poisoning. Chair's recommendation is to move this one out with a House Draft 1, a defective date, our standard 3,000 defective date. Questions, comments, or concerns? Vice Chair for the vote.
Voting on SB 2682, SD1, Chair's recommendation is to pass with amendments, noting the excused absence of Representative Nishimoto, who will be noted absent for the rest of the agenda unless otherwise announced. Any reservations or noes? Seeing none, Chair recommendations adopted.
Members, Senate Bill 3125, SD2, relating to medical care for minors. Chair's recommendation is to move this out with an HD1 and a defective date, our standard defective date. Members, any questions, comments, or concerns?
Comment, Chair.
Go ahead.
I just feel that this is a violation of parental rights, and I think we're moving in the wrong direction, so I'll be casting a no vote. Thank you.
Thank you, Representative Garcia. Any other comments, questions, or concerns? All right, Vice Chair for the vote.
Voting on SB 3125, SD2, Chair's recommendations passed with amendments. Rep. Garcia, no vote. Any other noes? Any reservations? Chair, recommendations adopted.
Thank you. Chair's recommendation for, okay, Senate Bill 2605, we're going to defer this to tomorrow, decision-making at 11:30 a.m. This room, March 14th, 2024. Members, moving to Senate Bill 3000, Chair's recommendation is going to be to defer this measure. We had a lot of really good conversation. It was good to see advocates on both sides come out and speak respectfully, and we will continue to work on this issue in other arenas. Members, comments, questions, or concerns? Seeing none, moving to Senate Bill 323.
Defer to tomorrow?
No, defer.
Oh, defer
Yes.
indefinitely?
Deferred indefinitely, yes. Senate Bill 3239 relating to medical debt. Going to move this out as an HD1. Not authorizing this, but allowing for a working group. Members, I will note in the Queen's testimony, they have noted that they are on the precipice of actually doing their own program in the private sector. So we want to make sure that the Office of Wellness and Resilience is working with those other private entities that are out there. We're going to transform this into a working group and add a defective date and any tech amendments identified by HMSO. Comments, questions, or concerns?
Who's on the working group?
We will put the Office of Wellness and Resilience as well as we'll put hospitals and insurers.
Yep, thank you.
Okay? And then anyone else determined by Office of Wellness and Resilience. Okay?
Yeah.
And a report back to the to this legislature or to the next legislature. Thank you, Representative Kobayashi. Comments, questions, or concerns? All right, seeing none. Vice Chair for the vote.
Voting on SB 3239 SD2, Chair's recommendations to pass with amendments. Any reservations or noes?
Reservations.
Reservations for Rep. Garcia. All others vote aye. Chair recommendations adopted.
Thank you. Members, I want to make sure that we don't lose sight of any bills and agendas that we might have. I believe we had a decision-making agenda for SB 2285. Okay, so we're adjourning the 9 a.m. agenda, reconvening the Joint Committee on Health and Homelessness, Committee on Human Services, 11:30 a.m. agenda for decision-making only. This is related to Senate Bill 2285. Members, I'm moving this one also because we had the Hui Ho'omana Task Force and testimony that came in today that we need to take a look at. We're going to move this one to the agenda for tomorrow, March 13, 2024, decision-making at 11:30 a.m. in this conference room. Chair Martin, anything to add? No, okay. Questions, comments, or concerns? All right, we are adjourned on that agenda. And just making sure that everything else on our 10 and 10:30 a.m. agendas have been moved. Those are confirmed, members. We are adjourned. Thank you.